Hi, I'm Marjorie Stanton at Best Self Behavioral Health. I'm the Vice President of Intensive Mental Health Treatment and Rehabilitation Services.
And I'm Kelly Whitman with Best Self Behavioral Health, and I am the Vice President of Substance Use Disorder Services and Housing.
So Kelly, I know we've discussed a few things about starting mobile treatment programs, but there were a few things I'm wondering if your substance use disorder team experienced similar to my mental health program.
Yes.
One of those things that I kind of wasn't aware of when we started that program was the impact of drive times and how that really changes the way you plan your day.
Right.
You know, sometimes even with a smaller county such as Erie County in Western New York,
Right.
there can be 45 minutes between appointments just from driving from one home to the next.
Yes. I think that kind of caught us by surprise as well, especially with the mobile substance use services. We do Erie and Niagara County.
Yes.
So the drive time could be an hour or more. And so you're right, planning the day out and taking that into consideration. That means compared to clinic, there's significantly fewer clients that you're going to be able to serve in the day.
Yes.
One of the pieces that we thought would be able to help with addressing that was having telemedicine in the vehicles.
Yes.
So the idea behind the telehealth was so that we would cut down on some of that travel time. But one of the unexpected barriers we ran into with that was just telehealth is a new concept in substance use services. So a lot of the prescribers have been a little hesitant to start with that. It's new to the clients. So really getting people comfortable with utilizing the telehealth and getting them to understand that that's going to significantly reduce some of that travel time.
Right.
And we can serve more individuals who live further away.
Yeah, we're experiencing that as well. It's really going to take the right type of training and presentation from the start with our consumers, and then giving them time to be comfortable with that so that they're feeling able to express themselves the way they need to within that modality of treatment. So we're experiencing that as well, and it's something that we're looking to start piloting more.
Okay.
But technology can work well for us, but there's times that technology goes down and systems go down.
Absolutely.
And you still need to get the job done.
That's right.
So that's a struggle.
Yes.
I don't know, we saw a heightened amount of folks that required our services due to physical disabilities as well, which for my programs really meant we needed to integrate that health monitoring at a heightened level that we didn't appear or think of ahead of time.
Right.
So that really requires my nurses to be really knowledgeable, not only in mental health treatments, but physical health treatments and connections to primary care, the ability for us to know what the next level of need or requirement would be, and then to find out-of-the-box solutions, because if our folks aren't accessing mental health treatment because of that barrier, they're also not accessing physical health treatments because of that barrier, and their discomfort with going to a provider with all these needs.
Absolutely. We definitely found that to be a barrier too. Definitely highlighted the importance of having an integrated treatment team.
Yes.
And you're right, like with our teams, we have nurses, we have prescribers, but in substance use treatment, we tend to have CASACs who are not trained in mental health.
Yes.
So we did run into several cases where someone who had a severe substance use disorder also had a pretty significant mental health disorder. And so we needed to make sure we had staff on the team who were trained and able to also address mental health and substance use. And then those physical ailments were also pretty significant for the population. So we've also been fortunate because we consult with you guys. We've had some cases that we've consulted with the mobile mental health team just to determine, you know, when someone had severe mental health and substance use, which mobile program would be best to serve them.
Right.
Because we really don't want individuals being treated between the two.
Correct. Yeah.
But definitely something that we did not, I think, anticipate in the
Yes.
beginning.
I think that's kind of a lessons learned for anyone or any agency that's going to try to start a program like that is we have each program to lean on one another to say what is the best level of treatment for this individual is, and then treat them in an integrated fashion, but making sure they're with the program that has the expertise for whatever we're really trying to hone in on as the first set of services.
Right.
Yes. So we definitely were thankful to have one another to lean on, and our teams have gone out together to assess when a case needs to be seen by both sides, and then come to a decision about, with that individual as part of the treatment team, what's the best treatment course for this person.
Yes, absolutely.
With that being said, a challenge or something I wasn't aware of is workforce and what it takes to have somebody who is, one, comfortable with community work, willing to work in the community. We have harsh winter, and so weather plays a factor in staff's comfort level in the community, because that means driving in snow. That means walking into someone's home who has not shoveled for you, so snow can be up to your knees at times. Knowing how to engage somebody in an atmosphere that might not be what you would consider a comfortable environment, such as hoarding conditions, poverty-stricken communities where, they have one lawn chair in their home as a place to sit. And we've had to get creative with training staff at how to assess living conditions and come up with a plan, because their environmental factors for this client are playing into mental health abilities to feel healthy. It's that social hierarchy of needs. And so there's two things going on there. Staff being able to assess a lot of different components at the same time, knowing how to make those community referrals to bring in other treatment solutions to this client, housing, health home services, mobile treatment solutions such as the VNA services to get primary coming into the home to help with medications, deliverable or community pharmacies where they're going to prescribe, will prescribe those medications, but then clients can't get to the pharmacy to pick those items up because that's their barrier, is leaving their home. So getting pharmacies to be able to deliver medications at the home. So that's the client side of assessment. And then staff's comfort in having to do all of that while being outside of a controlled environment of an office at a traditional setting.
Absolutely. That's so important. We were fortunate enough with the substance use mobile services that we were able to recruit a lot of staff who had experience doing outreach and community work. It's so important to have staff who are comfortable in that environment. When you're going into people's homes, you don't know what you're walking into. And it's really not work that just anyone could do. I think one of the pieces that we did not expect to face as strongly as we did was making sure the other treatment providers in the community, because one thing you mentioned was that, like, with the referrals and linkages and being familiar with the treatment providers. So I think we were familiar with the community treatment providers. However, with this new mobile service coming on board, a lot of the treatment providers were not as familiar with what we were going to be doing. And so there were a lot of concerns about maybe us taking clients from other places and, what is it that you're doing? You have this vehicle that's putting people on medicine within 2 days, and that's not responsible. And so we had to do a lot more education of the treatment providers on what the mobile services would look like, and really get them to understand and get on board with seeing how beneficial this was going to be for clients, because the purpose of the mobile team was to be temporary to stabilize and address the barriers. And ultimately, we want to link to those treatment providers. Well, for us to do that, they need to be on board with that. They need to be on board with this is a person we've started on medication for their addiction, and now we want to transfer them to you and we want you to continue. So they need to know that we went through an assessment and the person has been in treatment and it's safe to continue this treatment. They've been seen by a prescriber, and all those things. So I think some of the initial pushback when people heard there was this mobile van prescribing medications to individuals within a couple days, just kind of educating and preparing people for what that would really look like.
Right. That took a lot of effort on our end as well. The training of the community and what a referral would look like, and then what a referral wouldn't look like.
Right.
There is still choice in treatment, and I think some of our community providers have great intentions, but folks still have to be agreeable and willing to connect with treatment. And I think some of the perspective of the community was that we will show up every day until the person agrees. And while we'll be pleasantly assertive in trying to help folks realize that we really are a support for them, we are not able to mandate folks into those services. And so it took a lot of lift-off work to get the program off the ground, in the sense of educating our community and our own agency as to what a referral would be and what a referral wouldn't be.
Oh, we had some of that as well. We had a lot of getting onto medication is an obstacle in many places. It takes several weeks. So then we would get a lot of referrals for people who just wanted medication and not therapeutic treatment. So yes, educating on what a referral is and what a referral is not. I think that's kind of another unexpected situation that we faced, not knowing that the mobile substance use program would be seen as one of the main points of access for rapid access to medication-assisted treatment. So because a lot of the other treatment providers still had a longer wait to get people on the life-saving medication, a lot of people looked to our mobile services to refer and link someone within 24, 48 hours to medication. And so they know that through the mobile program, the person would get on, seen and on very quickly. And so we kind of by default became the point of entry for rapid access into medication-assisted treatment. And I don't think we originally planned for it to happen that way. But yes, a lot of treatment providers have made great progress in shortening their length of time to get people on the medication as well. But it was another unexpected piece to prepare for.
Yes. Going back to staff working in the client's environment, we experienced that families became a much larger presence in our treatment, meaning a family member was present when services were taking place. And that is very beneficial at times because it helps get the family on board. But a piece that we weren't expecting is our ability to explain to family that they should, or it would be beneficial to themselves and the family member that was our, client, to access treatment for themselves. So we had to become well adapted in how we explored that a family member would also benefit from getting services. And that's a tricky conversation to have with someone, because you have this identified individual who is seen as the one really needing the treatment. And while, yes, they need some services and we're there to help them, that individual can only get so well, quote unquote. And the family themselves, or the partner, or the support system also needed some work so that they could be well, and then together they could continue getting well.
Yes, we encounter that oftentimes. And I think at our first week with the mobile program, we went out to serve an individual and got to the home and ended up assessing and evaluating it was a wife that was referred, but the spouse also had an opioid use disorder severe, and there was an aunt in the home that lived in the home that also, so the entire family ended up assessed and coming into treatment, and actually that family is due to successfully complete next week. So, but it was like getting used to going in when you're going into the home, and we know with substance use a lot of times there's that family dynamic component, and but you need to be prepared to address that when you go into the house. There may be other people there that are also in need of services, and so it has happened on several occasions where we end up offering and providing those treatment services to more than just the individual that was referred. Yeah.
One thing that we worked with too, and this kind of plays into the sustainability of programs like this, is the frequent no-shows that occur. So even though individuals may have a barrier to succeeding or following through with traditional services, it doesn't mean they're always housebound.
Right.
And we'd go to homes frequently, even with lots of notice about your next appointment and things like that. We've had a lot of no-shows, and we had to figure out how to best work that into our program so that we are, between driving sometimes up to 45 minutes between appointments, and then when you get to that next home and no one's home, so a service doesn't take place, and then you're going to the next home, it really can be cumbersome to get enough services in a day.
Right. Absolutely. And sustainability, I think, is still a concern that we have. Our funding was a 2-year grant funded program. And so, and had it not been that our mobile services are also a part of our certified community behavioral health clinics, the CCBHC, so we're able to bill at a daily rate that's higher than what it would we be billing at the usual fee for service. So that has helped with some sustainability after that, if that should go away. And once this funding stops, we are billing for services. But I think there is the concern with, is this going to be sustainable should that support be pulled away? And I don't have an answer to that. It is something I know that's on a lot of people's minds.
It is on my program's mind for sure, because we started our program under the licensed behavioral health practitioner managed care waiver, where we can provide these services outside of the clinic, but that rate is still not large enough to equate for all of the nuances of this program, such as I can't always guarantee an intake can happen in 45 minutes because I walk in the door and, like we've said, some other family members need services. I need to do several referrals to other programs for emergency needs. And we need to be able to take the time with folks that they require. So we feel that concern as well, that I have a larger program or department because of CCBHC and what that funding means for us. But if or when that changes, the fee-for-service dynamic doesn't support the no-shows, the drive time, the need to have longer sessions with folks and do some other services outside of the traditional intake. And that's concerning.
It is.
So we're, as an agency, I know you and I have discussed, ways that we're going to try to be creative, but without the right financial streams, we can only be so creative.
That's right.
Yeah. One thing that I hope to pilot is to make sure that people are aware of the decrease in hospitalizations that our programs have made and changed for our area and for our programs. There'll be research as part of our presentation, but the ability to see folks in their environment, it helps prevent the increase in symptoms and helps to stabilize folks prior to it hitting a point or a level where they require inpatient treatment. And I know you guys have experienced that as well.
Yes, we have. unfortunately, we don't have the great data statistics. I know you
Yes.
did some actual research and got and pulled some numbers on it, which is
Right.
wonderful. But that's going to be so important, I think, in trying to demonstrate how much these type of services are needed and how much it really, really decreases the overall,
Yeah, the cost.
yes, on the entire system. It's a huge savings, so
Yes.
it's great.
Safety seems to be a large concern that my program talks about regularly and tries to get creative at making sure that we are setting up safe work environments for our
Yes.
staff, because I think you had said earlier, we don't always know what we're walking into.
That's right.
You can pre-screen as much as you can over the phone, but what is seen as an unsafe environment to the screener or to the person answering those
That's
questions
right.
is very different to the person walking in the door
Absolutely.
and providing those services. So
Absolutely.
we have a few things that we've done to try to ensure safety, and I think you guys have really followed suit with that. Is we do a lot of pre-scheduling so that staff know what addresses that folks are going to be at. And then we have an on-site staff member, a support staff member, who's able to access each staff or counselor's schedule
Yes.
to know where they're going to be and at what time frame.
Absolutely.
We've also set up a group text message system where staff are saying, I'm checking in to appointment number 2, and then I'm checking out of appointment number 2, and that everybody is a part of that, including the on-site staff member,
Right.
to know safety in and then I'm safely out.
Yes.
And then end of the day check-ins.
That's
has
really
been a
good.
part.
Yeah, safety is definitely very key. We try to always go in pairs, and as you know, there are situations where you can't, but we try to, the peers on our teams are very, very important to us being able to go out in groups of 2. So we typically pair them with a peer and a counselor, and also with that, the individual that we're going to see can get a couple services, or sometimes we'll pair a peer with a nurse, but we'll, a couple different disciplines so that they can see that individual and deliver a couple services, but also for safety reasons, there's another person. But yes, and then all the things that you all do as well.
Yes.
Safety is so important.
And speaking to going out in pairs, we try that as well. But the concern is even, the current model may sustain financially that, but after that,
no.
we are really going to
Yes.
struggle, because to say that each person is doubling up, you even see less folks
That's
as
right.
a program
That's right.
financially in billable services. So
Have to make those units.
yeah.
Yes.
So that makes a struggle,
It
So all of
does.
these factors will play a role in
Yeah.
and how we're able to perform services in the future if changes happen within
Definitely.
billing systems.
Right. For sure.
Yeah. It's been a great learning experience, though.
It has.
It has.
It has.
Yes.
And I'm sure it will continue to be so as we.
Yes.
I think we're into our second year of the funding, so yes,
I'll
we'll
be-
see how it goes.
2 years in April will be 2019 will be we've been doing this for 2 years now, and it's grown, and we've been willing to realize that the program in and of itself just needs to be exceptionally flexible. And I think that's the biggest takeaway for us,
Yes.
is that whatever we originally had planned,
Right.
once we've noticed a gap somewhere in our systems of treatment in this area, we've
Yeah.
realized we've had to expand what our breadth of services are so we can fill that next gap and make sure that folks just don't go without treatment.
Right, absolutely.
That's so important. I didn't think about that till you just said it, but yes, remaining open to changing to meet the need of the community and just being flexible in that way, which is not always easy, but and then we try to balance between understanding we can't be everything, but we
Yes.
want to make sure we're meeting the need. So how do you balance that? Yes.
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 A struggle, lessons learned.
Yes.
But it's also great because our community has really seen such great improvements in
yes.
the opioid epidemic
Yes.
and folks decreasing hospitalizations.
Absolutely. Yes.
So it's been great.
It has.
It's been a great experience.
Yes.
We're lucky we have both programs
We
to
are.
balance one another.
Indeed.
Yes.